Hello and welcome to my ophthalmic teacher, and we're going to talk about applied anatomy and physiology of cornea. So, a little bit about the embryology. Uh, Now, as you know, that the eye is formed from the optic vesicle, which is a part of the forebrain. So, in the optic vesicle, several structures are developing from the neuroectoderm, mesoectoderm, as well as the surface ectoderm. All the three layers give rise to structures in the eyeball, along with the neural crest cells, which migrate to that area. So, epithelium is formed from the surface ectoderm. This is the epithelium. At about 40 days of gestation, the superficial squamous and the basal cuboidal layer are present. Next, at 7 to 8 weeks of gestation, mesenchymal cells migrate into the primary corneal stroma, right? So here, at about 7 to 8 weeks, the mesenchymal cells have migrated into the primary stroma. So this is what the stroma now looks like. And at 3 months of gestation, the cornea is three-layered. All further derivatives are obtained from these three layers. So that's the stratified epithelium, the stroma, and the endothelium, a three-layered structure at the age of 3 months. Now, this is a diagrammatic representation of the slit lamp view of the cornea, and this is the actual view. As you can see, this slit of light is the cornea. The dark space behind it is the anterior chamber, and this is the crystalline lens, which shows a cataract. A section of the normal human cornea looks like this when stained with H&E stain. So that's the histology of a normal cornea. Now it is very, very important to remember all of these dimensions. Remember, the cornea is a transparent watch glass-like structure forming the anterior 1/6 of the eyeball. The anterior surface has this horizontal and vertical diameter. The posterior surface has a uniform diameter of 11.5. Thickness in the center and the periphery should be remembered. Radius of curvature is more for the anterior, less for the posterior, making the posterior surface of the cornea more curved. The refractive power of the anterior surface is plus 48 because it acts as a convex surface, and that of the posterior is minus 5 because it is a concave surface. So the net power is plus 43. Going by these dimensions, the cornea assumes this shape. You see, this is the shape of the cornea, thinner in the center than the periphery, with the posterior surface more curved. And most of the refractive power, that is of plus 43 diopters, is concentrated in this central 5 mm of the cornea, which is the most important part. Looking at the histology, the cornea has 6 layers. So here come the Bowman's membrane and the descemet membrane. And just above the descemet membrane is a more recently discovered layer known as the predescemet or the Duas layer. With age, there is increase in thickness of the Bowman and the descemet membranes, both of which are acellular structures. The epithelium in detail, the surface stratified or flattened cells, the wing cells, and the basal columnar cells. These little columnar cells have intercellular junctions and they have hemidesmosomes which attach them to the underlying Bowman's layer. Coming on to the corneal stroma. Now this is a highly magnified and electron microscopic structure of the corneal stroma in a cut section and in the longitudinal section. And this is what the corneal stroma looks like on ultrastructure. So these you see are the collagen fibrils. And around them, the colorful ones are the proteoglycans. These proteoglycans are keratin sulfate glycosaminoglycans or dermatin or chondroitin sulfate glycosaminoglycans. So this is the ultrastructure of the corneal stroma. The corneal endothelium. This is what the corneal endothelium looks like on a specular microscopy. It is a monolayer of closely interdigitated hexagonal cells. It has a very important pump which plays a vital role in the corneal transparency. The density of these cells is 6,000 at birth, and it gradually decreases such that the average adult endothelial cell density is in this range. Corneal edema is known to occur below 500 cells per mm square. Endothelium does not regenerate but shows polymegathism, or increase in size of the existing cells to cover a defect. Nerve supply of the cornea. This is a very, very important question for MCQs, Viva, short note, long question, everything. So, the nerve supply comes from the nasociliary nerve, which you must know is a branch of the trigeminal nerve. Long ciliary nerves of the nasociliary nerve enter the eyeball around the optic nerve. They run anteriorly in the suprachoroidal space, and a short distance from the limbus, they pierce the sclera, connect with each other, and form the pericorneal plexus of nerves. This is at the limbus. Now, from this pericorneal plexus, myelinated trunks emerge and enter the cornea. They go about 1 to 2 mm inside the stroma, and then they lose their myelin sheaths. They divide and form three networks. So the first plexus was the pericorneal plexus of nerves formed by the long ciliary nerves, from which little branches emerged and formed three smaller plexus in the cornea itself. What are these three plexus? The first is in the midstroma, or the stromal plexus, consisting of unmyelinated nerves. From the stroma, these nerves pass anteriorly and form another plexus below the epithelium, the subepithelial plexus. And finally, they move from between the epithelial cells to form the intraepithelial plexus. And by now, they have lost the Schwann cell coverings also. So, the intraepithelial plexus consists of naked nerve endings or naked nerve terminals. This is the reason why a small corneal abrasion is very, very painful, and the cornea is a very sensitive structure. The blood supply of the cornea, it is an avascular structure except for the periphery, where the blood vessels invade for about 1 mm, and diffusion of tissue fluid from the vessels at the periphery and the aqueous humor happens. Oxygen supply. Cornea is aerobic metabolism mostly, in contrast to the lens where the metabolism is mostly anaerobic. The cornea can function only up to 6 to 7 hours anaerobically. What are the metabolically active cells? The three primitive layers are the metabolically active cells. Oxygen is derived from the tear film and the limbal capillaries. Glucose is mainly derived from the aqueous and the limbal capillaries. Coming on to the corneal physiology. In corneal physiology, we'll be talking about two things, the transparency and the wound healing. There are several factors responsible for corneal transparency. Now, how does the epithelium play a role here? The epithelium is a homogeneous refractive index. There are tight intercellular junctions. It is hydrophobic in nature, that is, it keeps water out, and it is lined on the outside by microvilli. These microvilli hold the mucin of the tear film on it. So these are the factors attributed to the corneal epithelium for the corneal transparency. So little microvilli over here holding the tear film to it, a homogeneous refractive index, tight intercellular junctions, hemidesmosomes, and a hydrophobic nature. Stroma. The most popular theory that explains the corneal transparency is the Morris theory, which is related to the collagen fibrils. The collagen fibrils are regularly arranged in the lattice, separated by less than a wavelength of light, so that any irregularly refracted rays of light are eliminated by destructive interference. So this distance is less than the wavelength of light. This is what the Morris theory states. Now, if there is any separation or disruption in this arrangement, what happens? The transparency is lost. With advancing age, the cornea becomes less transparent and develops opacities because of condensation such as lipids in the deeper stroma. We've already discussed the corneal degenerations in the previous classes. First factor, epithelium. Second factor, the regular arrangement of collagen in the stroma. Third, the cornea is an avascular structure. Fourth, it is maintained in a state of relative dehydration by a balanced osmotic gradient. Now, this gradient is maintained by two forces. Forces that are trying to absorb water into the cornea, that is the swelling pressure which is exerted by the glycosaminoglycans present in the stroma, they tend to absorb water, and intraocular pressure. Intraocular pressure is trying to push fluid from the aqueous into the cornea. So these are the forces that are causing water to enter the cornea or forcing water into the cornea, versus forces which draw water out of the cornea. One is the sodium potassium ATPase pump, which is an active pump. It pumps out ions and creates an osmotic gradient, and water follows out. Second, evaporation of water from the tear film, a passive procedure, makes the tear film hypertonic and draws water out. So there has to be a meticulous balance between these two forces so that overall the state of the cornea is that of relative dehydration. So this is just a diagrammatic representation of the forces that I was talking about, the stromal pressure and the intraocular pressure trying to keep the water in, versus tear film pressure, evaporation, and the endothelial transport trying to push the water out. Apart from this, epithelium, endothelium are hydrophobic structures. Trauma to any of these layers produces edema. Stroma is hydrophilic. The hydrophilic property of the stroma is very important for drug transport. Any acute rise in intraocular pressure, any problem in any of these forces is going to disrupt the osmotic balance, open up gaps in the endothelium, and push water into these cells of the epithelium and the stroma. Lastly, we're going to talk about corneal wound healing. So, this is again a diagrammatic representation of the epithelium and the stroma. So if some injury happens and it is superficial, involving only the epithelium, it rapidly regenerates from stem cells located in the palisade or vote at the limbus all around the cornea. These are specialized cells or the stem cells of the cornea, mitotically active cells with an increased surface area of the basal cells. So they fill up that epithelium that is lost, right? What happens if the injury is deeper? Look here. The injury has penetrated the Bowmans and reached the superficial stroma. So there is infiltration of macrophages and neutrophils, which secrete some growth factors and start an inflammation. This inflammation stimulates the fibroblasts to lay down scar tissue. And this is the scar tissue that is laid down. So you see, the epithelium can be regenerated, but Bowmans and stroma are not regenerated. In fact, scar tissue is laid down in their place. That is why the corneal scarring happens with wound healing. So remember, if the Bowmans is damaged, it does not regenerate but is replaced by fibrous tissue, as is the stroma. If the descent is damaged, it can be regenerated to some extent by the endothelial cells. And if the endothelium is damaged, it does not regenerate, only polymegathism happens. Corneal vascularization. So this is an abnormal picture showing superficial corneal vascularization. We know that the blood vessels do not go beyond 1 mm into the clear cornea. So this is abnormal and this happens in inflammation. Transparency is often compromised because of this process, and a corneal opacity may develop if the inciting agent is not removed. When the inflammation subsides, these blood vessels are going to be empty of blood, but they are going to remain as ghost vessels. These are just examples of some conditions where there is loss of corneal transparency. Here, this is basically an infective corneal ulcer with infiltration in the corneal stroma and a hypopion. This is the climatic droplet keratopathy that we have seen in our chapter on corneal degenerations, and this is advanced keratoconus showing protrusion and thinning at the apex, right? So hereditary disorders, climatic conditions, anything can affect and cause corneal degenerations. So thank you for listening, and you can always go back and revise the chapter on my YouTube channel, My Ophthal Teacher.